So, in our discussion about the gastroesophageal reflux disease, abbreviated as GERD, we will cover topics including the GERD definition, causes, clinical features, classification, diagnosis, treatment, and complications. So, the gastroesophageal reflux disease is a gastrointestinal disorder characterized by regurgitation of acidic stomach content into the esophagus or beyond into the mouth, the larynx, or the lungs, leading to irritation and inflammation in these areas. So as you can see in this picture here, the stomach content are regurgitating into the esophagus here and causing irritation in the esophagus. Now, GERD is the most commonly diagnosed gastrointestinal disorder in the United States, affecting 20% of United States population. Now, there is no specific cause for the gastroesophageal reflux disease, but there is risk factors, and to understand the risk factors, first we have to understand some points about the anatomy of the esophagus and the stomach. So we have the esophagus here connecting to the stomach, and at the connection of the esophagus to the stomach we have the lower esophageal sphincter. So here we have a sphincter, and this sphincter maintains high pressure to prevent the acid from returning into the esophagus. So normally this sphincter is contracting to prevent the acid from returning to the esophagus. Now back to the risk factors. So we have risk factors related to the esophagus. So those include esophageal dysmotility, and this means that there is a problem in the peristalsis movement of esophagus, leading to impaired esophageal acid clearance. Also in the risk factors, we have risk factors related to the lower esophageal sphincter. So we have either impairment in the tone of the lower esophageal sphincter, or we have a transient lower esophageal sphincter relaxation, leading to the opening of the lower esophageal sphincter and acid regurgitation. Now after that, we have problems related to the stomach, and those include delayed gastric emptying, and that is when there's problems in the stomach emptying. So it empties food slowly, leading to higher risk for acid regurgitation. And we also have risk factors related to the anatomy, for example, the presence of hiatal hernia. And hiatal hernia is explained in this picture here. So normally we have the diaphragm here, and it is supporting the lower esophageal sphincter here. But in hiatal hernia, there is part of the stomach and the lower esophageal sphincter is moving up, and this is the part here. So it is herniating out of the diaphragm up, and this would lead to the lower esophageal sphincter here having no support from the diaphragm. So the diaphragm cannot support the lower esophageal sphincter because it is displaced upward, and this would lead to the lower esophageal sphincter having less pressure, and this means there is higher risk for acid regurgitation. Now also in the risk factors we have increased intra-abdominal pressure, for example in obesity and in pregnancy, and that is because the higher abdominal pressure would press against the stomach, leading to the regurgitation of stomach content upward. In the risk factors we also have psychosocial stress, because stress leads to higher acid secretion and higher potential for acid regurgitation. And also we have impaired saliva production because the saliva neutralizes acid. So once we have less saliva, this means that we have less ability to neutralize the acid. Now, other risk factors include patient age higher than 50 years old and also lower socioeconomic status, and also tobacco use and consumption of alcohol are both risk factors. And then we have connective tissue disorders and in postprandial supination, because when there is supination, the stomach would be leveled with the esophagus, and this means that the stomach content has an easy way to regurgitate back to the esophagus. Now, risk factors also include the use of medications like the anticholinergic drugs, the benzodiazepines, the non-steroid anti-inflammatory drugs, or the aspirin, the nitroglycerin, the albuterol, the calcium channel blocker, the antidepressants, and the glucagon. Now let's talk about the clinical features of the gastroesophageal reflux disease. So it most commonly present as heartburn and regurgitation, and heartburn is retrosternal burning sensation that may radiate to the neck and it occurs after meals. Regurgitation, on the other hand, is food regurgitation into the mouth or hypopharynx that occur after meals. So most commonly the patient would be suffering from both of these symptoms. Now also the GERD may present as chest pain, and when it presents with chest pain, it is hard to be differentiated from acute coronary syndromes like myocardial infarction and angina, because they also lead to chest pain. Now GERD may also present as, which is also called burping, and it may also lead to nausea, dental erosions, and that is due to the acid damaging the teeth, like you can see in this picture here. And it may also lead to chronic cough, and that is due to the irritation of the throat by the regurgitated acid. And GERD may also lead to asthma, because the acid would act as an asthma trigger, and it may lead to dysphonia and hoarseness because it irritates the larynx, and it may lead to globus sensation, and that is when the patient sense a globus inside their pharynx. Now we also have alarm symptoms. Those include dysphagia, odonophagia, anemia, hematemesis, and weight loss. Now it is very important to remember these symptoms because they are linked with cancer development, and they are also linked to development of complications. Now let's talk about the classification. So according to the endoscopic and histopathologic appearance, the gastroesophageal reflux disease is classified into three types. So we have the non-erosive reflux disease, abbreviated as NERD, and this is also known as reflux esophagitis. And this is the most common type of the gastroesophageal reflux disease, accounting for 60% of all cases. Now we also have the erosive esophagitis, and this is characterized by erosions and ulcer development inside the esophageal lining. And then we have the Barrett esophagus, which is the least common, and it is characterized by metaplastic changes. So in all of these types, there is some histopathological changes affecting the esophageal lining, including inflammation, basal cell hyperplasia, papilla elongation, and dilation of intercellular spaces. And those changes are caused by the gastric acid, the pepsin, and the bile salts that come into contact with the esophageal lining from the regurgitation from the stomach. Now, the erosive esophagitis is characterized by erosions and ulcer formation, as we mentioned, in the esophageal mucosa, in addition to the changes mentioned above, meaning the inflammation, the basal cell hyperplasia, and the others. And in Barrett esophagus, which is the third type, there is also metaplastic changes to the esophageal lining from stratified squamous epithelium into simple columnar epithelium, in addition to the previously mentioned changes. And the Barrett esophagus is shown here. So here is the normal esophagus lining. So here it is stratified squamous, while in the Barrett esophagus lining, we have the simple columnar epithelium. Now let's talk about the diagnosis. So the diagnosis is made clinically based on the patient history and response to the proton pump inhibitors. So the diagnosis in most patients is made on the patient history and response to the proton pump inhibitors. Now there is exceptions. So if the patient present with alarm symptoms, then they are sent to be evaluated by the esophagogastroduodenoscopy to rule out GERD complications or peptic ulcer disease. Now the alarm symptoms, again, they are the odynophagia, the dysphagia, the anemia, hematemesis, and weight loss. So if the patient mentions any of these symptoms, then they have to be sent to be evaluated by the esophagogastroduodenoscopy to rule out the GERD complications or the peptic ulcer disease. Now the GERD complications include erosive esophagitis, which is the second type of GERD, and the Barrett esophagus, which is the third type, and the esophageal strictures and esophageal adenocarcinoma. So we send the patient for endoscopy to rule out these complications or the peptic ulcer disease. Now the American College of Gastroenterology guidelines recommend the screening for the H. pylori infection in patients with the gastroesophageal reflux disease. So every patient diagnosed with GERD have to be screened for the H. pylori infection. And we have multiple screening tests for H. pylori, for example, the stool antigen test and the urea breath test. Now we also have the radiographic studies in the diagnosis of GERD, and those include the contrast studies, but they are not required for diagnosis, and they are ordered only if there is suspicion of severe esophagitis, or if there is esophageal stricture, or if there is hiatal hernia or tumors. Now, in the diagnosis, we also have the ambulatory esophageal reflux monitoring, and this is a device that is inserted to monitor the acid reflux, and this is indicated in refractory GERD and in patients with normal endoscopy evaluation, but they have GERD symptoms to confirm the diagnosis of GERD. Now, the ambulatory esophageal reflux monitoring utilizes a telemetry pH capsule, or it utilizes a transnasal cath, and both of those can be used to detect the acid reflux and the frequency of the acid reflux and the correlation of the acid reflux with the symptoms. And this is very helpful in diagnosing GERD in refractory cases and in patients with normal endoscopy. Now, there is very important note that you should look for is that if there is suspicion for acute coronary syndrome, like the patient having a chest pain, then the patient have to be sent for electrocardiogram, and cardiac enzymes and other tests should be done to exclude the acute coronary syndrome. And that is because the acute coronary syndromes, like the angina and the myocardial infarction, have similar symptoms as the GERD. And even the anti-secretory medications like the proton pump inhibitors that are used in treatment of GERD might relieve the pain in acute coronary syndrome too. And this makes it very hard to differentiate the two diseases. Now let's talk about the treatment. So in the treatment we have the lifestyle modifications, and this is the cornerstone of GERD therapy. The lifestyle modifications include weight loss in obese patients, and it also includes avoiding meals at least 3 hours before bedtime, and also maintaining a good sleep hygiene, as shown that minimal sleep disturbances resulted in suppression of the lower esophageal sphincter relaxation. So there is less relaxation of the lower esophageal sphincter with better sleep hygiene, and this means that there is decrease in the acid reflux. Now, lifestyle modifications also include elevation of the head end of the whole bed by 8 inches. This would help improving the GERD symptoms, because this would make the esophagus on higher level than the stomach and prevent the acid regurgitation. And we also have diet modification. This includes elimination of spicy foods, carbonated beverages, caffeine, and high-fat foods, and chocolate. Now it also includes avoiding bending or stooping, because both of these movements would induce the acid regurgitation. Now in the treatment we also have the medical therapy, and this is indicated in patients who do not respond to the lifestyle modifications. And medical therapy include the use of antacids. Those are medications that neutralize the stomach acid. Examples for them is the aluminum hydroxide and the calcium carbonate. And those I already explained in a separate video on the same playlist as this video. And we also have the anti-secretory medications. Those include the H2 receptor antagonists and the proton pump inhibitors. And both of these are also explained in separate videos added to this playlist. Now, the proton pump inhibitor therapy is the most effective for all types of GERD. And the American College of Gastroenterology guidelines recommend the proton pump inhibitor therapy once a day dosing before first meal of the day, and if this fails, then twice daily dosing is done. Now in the medical therapy we have the prokinetic agents. Example for those is the metoclopramide and the domperidone. And the prokinetic agents used in GERD is limited due to lack of data on their efficacy, and also due to their profound adverse effect profile, especially their effect on the central nervous system and cardiovascular system. Now in the treatment of GERD we also have the surgical therapy. And surgical therapy indications include patients with medically refractory GERD. And also indications of surgical therapy include patients who are not compliant to lifestyle modifications or pharmacological treatment. Also, we have patients with large hiatal hernias. Those require surgery to help fix their hiatal hernia. Also, patients who desire to discontinue long-term pharmacological treatment. Now, surgical options include laparoscopic Nissen fundoplication and laparoscopic anterior 180 degrees fundoplication and bariatric surgery in obese patients and magnetic sphincter augmentation and transoral incision-less fundoplication. Finally, let's talk about the complications. So the complications of GERD include erosive esophagitis, and this is characterized by erosions or ulcers of the esophageal mucosa. And we also have the development of strictures, and that is because the chronic acid irritation of the distal esophagus lead to scarring and strictures, and this lead to the patient presenting with dysphagia or food impaction, and the treatment of strictures is with esophageal dilation and proton pump inhibitor therapy to prevent further scarring. Now in the complications we also have Barrett esophagus, and we already mentioned that this is a metaplastic changes in the esophageal lining from stratified squamous into simple columnar, and the risk factors for Barrett esophagus include Caucasian males older than 50 and obese patients and patients with history of smoking. And with Barrett esophagus, there is high risk of development of esophageal adenocarcinoma. So these patients with Barrett esophagus have to be followed to make sure that they don't develop the adenocarcinoma. Other complications include laryngitis because of the acid irritation to the larynx, also sinusitis because of the acid irritation to the nasal sinuses, and we also have idiopathic pulmonary fibrosis because of the acid irritation to the lungs and the esophageal adenocarcinoma. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And this video is a part from a bigger course. It's called Therapy for the Gastroesophageal Reflux Disease free course. Link will be in the description of this video.